Okay, well, what I'd like to do is do a little bit of shift, and rather than talking about signal transduction, talk about mechanisms of drug toxicity, because I mean, that's a part of drug mechanisms too. And then after today, what I'd like to do is maybe review some papers on some of the newest drugs that are coming out in terms of how they do what they do. Uh, what's that drug that seems to be lowering uh, that's good for weight loss in terms of decreasing just appetite? Is it Ozempic? Is that
Yes.
it?
Yep.
Yeah. So maybe we'll learn about why that is, because I suspect, well, and what that link is to the endocrine system, at least in terms of regulating blood glucose. So that's sort of what we're going to be looking at next week. I'm sorry, I'm not in my best form today. I am just really not fully recovered, but I didn't want to let you guys go for an entire week. So we'll take a look at these notes on drug toxicity and take a look at the mechanisms. So I'm going to do a share screen. So one truism in this world is that there is no substance which is purely non-toxic. Everything that you come in contact with has the potential to become toxic. I've read about instances where on the radio they had some kind of contest about who could drink the most water, and the person who won the contest died from just having too much hydrosis. So, as Paracelsus said back in the 1500s, all things are poison and nothing is without poison. The dosage alone makes it so a thing is not a poison. So toxicity just simply revolves around dose. And there are some things that are particularly toxic, like cyanide as an example, and other things that are less so. And so in terms of drug toxicity, what that relates to is disruption of homeostasis. That is the normal range of physiologic functions, seeing things like body temperature, blood pressure, respiration, things of that sort, blood glucose. And so toxics, things that are toxic, are that way because of the disruption they cause, homeostasis, bringing normal functions out of the normal range at the level of the cell, the tissue, and the organ. If the disruption is marginal, typically homeostasis can be restored. If that toxicity results in a threshold of cell death, then there'll be irreversible organ system dysfunction and death. So this is just a basic dose response curve that's looking at blood levels and what hopefully good. So if someone takes a particular dose, a little while ago I just took some pseudoephedrine. Does anyone know what the side effects of the pseudoephedrine are? You guys are all online. Why don't you look it up?
So it says headaches, dry mouth, feeling restless, nervous or shaky.
Does it say anything about elevated blood pressure? Because it's a vasoconstrictor, right?
Yes.
So hopefully with the Sudafed that I just took over a period of time, blood level will rise into the therapeutic range and not get into the toxic range. Now I just took one sustained release tablet. If I'd taken the box, it would be up here. And so blood pressure would be very high. Maybe I could stroke out, something like that. So that's bad. Typically with many drugs that are given orally, the dosing tries to keep the blood level within the therapeutic range. And so with repeated dosing, hopefully the drug does not enter the toxic range, but still remains in the therapeutic range. So that's with, this is something I'm certain you've all seen before. Now, there are different ways you can look at toxicity. One is, let's say, if I took my pseudoephedrine and you took my blood pressure every half hour for, I took a 12-hour sustained release dose. So if you took my blood pressure every hour for 12 hours, that is just a conventional dose response curve. And you could follow the change in my blood pressure over time. However, there's a different way of looking at the data, both for drug effect, but also toxicity, which is a quantal response. So here, with a quantal response, rather than looking at individual patients or average changes in some factor, what you look at is the percent of patients that are responders or non-responders. So this is a graph of loss of circulating blood oxygen versus a particular dose of 3 different opiates. Just so we're on the same page here, how do opiates, from a mechanistic standpoint, reduce circulating blood oxygen? Anybody? What do you think, Vivek? Anyone want to help him out? Or you got it?
Maybe decreasing the respiratory, decreasing the respiratory rate.
Well, that's right. Opiates reduce respiratory drive. So with a particular dose of these drugs, you can see that blood saturation or oxygen saturation in the blood is normally around 95%, but depending on the dose, it can fall. And that then would lead, if you decrease oxygen saturation of the blood, that can lead then to significant toxicity. So for a normal, healthy individual, it's around 95. Now, considering my respiratory infection, I don't know if I'm there. Hopefully I'm not down here. But patient with chronic obstructive pulmonary disease, oxygen exchange across the lungs is impaired. So normal circulating blood saturation is going to be lower. Patient becomes hypoxic, where they could actually be symptomatic between 85 and 94, and then severely hypoxic if blood oxygen saturation falls below 85%. So any drop of 3% or more indicates some toxicity. And we were relating this to morphine, as I think I may have mentioned in the past. If someone has a lethal overdose of an opiate, the mechanism of death, does anyone know what it is?
Respiratory paralysis.
It's respiratory arrest. They just stop breathing. So you're all used to, at this point, dose response curves that look like just sigmoidal curves on a semi-logarithmic scale. However, there are monotonic dose response curves, and here's one that's sort of U-shaped, and with dose of a particular substance, if you don't have enough, mortality rate is high. As you increase exposure to the substance, you'll fall within a range that will maintain homeostasis. You fall above this, you get threshold for adverse response. And then as you continue to increase the dose, you go back into the toxic range, and it can in fact be fatal. Can anyone give me an example of a substance that would produce this type of toxicity curve?
Can I, sir?
I'm sorry, say again?
Sir, maybe digoxin.
Digoxin?
Yeah.
Can people live without digoxin?
Oh, sorry, I might be wrong with this.
Right, this is classic for essential nutrients. So as an example, if someone doesn't have adequate amounts of iron in their diet, they can't survive. If you have sufficient dietary iron, you can have adequate functional hemoglobin, which will then sustain oxygen circulation. However, if you go into high doses of iron, you'll get iron toxicity. This is especially associated with liver. Now, one of the most common causes of this iron toxicity overdose is children taking their mother's prenatal vitamins that are typically high-dose iron. And the vitamin looks appealing, and the kids just start eating it. This is a hockey stick Dose response curve. What could be up with? Any idea what could cause this type of toxicity response? Can you think of a drug that would produce this? Where the drug is non-toxic till you hit a threshold, and then once you exceed the threshold, the toxicity goes up. I'll give you a hint. It's a very common analgesic, antipyretic.
Acetaminophen.
Starts with an A.
Acetaminophen.
Acetaminophen, right. And the reason is, within therapeutic dose, what happens is acetaminophen is metabolized, but it has a highly reactive metabolite that then can attack proteins. However, normally there is glutathione, which will enter into a phase 2 metabolic reaction, inactivating the metabolite. However, above a certain threshold, the glutathione becomes depleted, and then the metabolite will wreak havoc, especially with hepatocytes, which is where much of the metabolism takes place. I don't know if I told you this story or not. I'll tell you a story. Before I came to Duquesne, I used to work in a poison control center. And occasionally, especially on a Friday or Saturday night, this is back in the 1980s, I'd get a call typically from an adolescent female who'd had a fight with her boyfriend, and she was going to show him how upset she was, and she would down an entire bottle of Tylenol in what we would call a suicidal gesture. The thinking was that, or her thinking would be that, well, I've heard that Tylenol is safe, which it is in the therapeutic range. And so she's going to show her boyfriend how upset she is, and she downs the entire bottle. Then she gives the poison control center a call saying, well, I just did this. I'm okay, aren't I? And then we sort of say, no. And back in the 1980s, this is before caller ID. So we don't know where the person is or who the person is. So we'd keep them on the telephone line for maybe about half an hour while we're dispatching the police to go to the person's house and pick her up. And so we'd have to hear the story of what a bad man her boyfriend is, and she loves him, but he doesn't love her, blah, 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 okay? And what would happen if she hadn't called, she'd be sick, nausea and vomiting for maybe about a day, and then she'd feel better. In the meantime, her liver would be destroyed, and about a week later, she would develop jaundice, and her liver would become non-functional. And in the 1980s, there were no liver transplants, and she would die. So it could be fatal. But anyway, that's an example of a hockey stick. Sometimes you could see this type of dose response, not so much to a chemical, or you could, in terms of certain things in food, they'll say, well, this ingredient is safe up to this dose, and so if you stay below this dose, you're okay. Also, in terms of exposure to radiation, as long as you're below a significant threshold, the likelihood of having damage is reduced. Although, with radiation, is there any particular dose where there is no effect? It's all in probability. So the answer is the likelihood is really, really small, but it's not zero. That, though, is different from this type of hockey stick. So, if you look at drug effects, you could have a therapeutic response. So, in the case of my pseudoephedrine, I'm hoping that I will have less respiratory congestion. That's the goal. And hopefully with that one extended release caplet, I'll be okay. However, in terms of toxic effects, adverse effects, there can be a number of different types of adverse effects. One is pharmacological. Can anyone give me an example of a pharmacological adverse reaction? We already spoke about at least one. Well, opiates can induce respiratory, they can suppress respiratory drive. In therapeutic range, it's not an issue. In toxic range, it's just an extension of what the drug actually does, and so you have an overdose. Or, let's see. Someone took, let's say, an overdose of a vasodilator. They could become hypotensive. And that's just an overdose leading to a physiologic response that produces toxicity. What about biochemical?
Increased liver enzymes.
I beg your pardon, say again?
Increased liver enzymes.
Right, so the example there is the acetaminophen example.
Yeah.
Another example could be methanol toxicity, where methanol in and of itself is non-toxic. The metabolite of methanol is formaldehyde, which is very toxic, and formaldehyde's metabolite is formic acid, which is a component of bee sting, very toxic. So that's typically a situation in which the parent compound is non-toxic, but the metabolite is, right? Another example of that is cigarette smoke that's inhaled. It has highly reactive heterocyclic molecules that are carcinogenic and disrupt DNA function. Teratogenic is what? What is teratogenic from a definition?
Causing a birth defect.
Exactly so. Anything that causes birth defects.
Thalidomide.
Say again?
Thalidomide.
Thalidomide is a classic example. Thalidomide was a drug that was approved in Europe to treat the nausea that comes along with pregnancy in the first trimester. And they did all kinds of testing, I think, in animals, and it was safe. But when they released it, it caused severe birth defects like babies born without arms or legs, really bad stuff. Another example is ethanol. So women are always cautioned not to drink during pregnancy because the baby could develop fetal alcohol syndrome that's associated with mental retardation and certain facial deformities. And then there can be toxicity that disrupts the DNA, which then can lead to mispairings or the synthesis of abnormal proteins, which then can be toxic. And if it is an effect in a somatic cell, you can get, let's say, disruption in the proteins that are responsible for controlling cell replication. And if you disrupt those enzymes, the cell can just start replicating in an uncontrolled fashion, which is what cancer is all about. If, on the other hand, the toxicity is to a gene line, we're talking about spermatocytes or oocytes, you can get mutations that are carried on from generation to generation to generation, which can be problematic as well. Any questions about anything that I've talked about so far?
Dr. Johnson,
Yes.
Vivek here. Dr. Johnson, how will you bucket kind of differentiate pharmacological adverse effects from the rest of the others? Because every, say for example, biochemical reaction or a terrogenic effect, genotoxicity, everything should ideally fall under pharmacological effect, right?
I have to confess, I'm having some difficulty understanding you because you get a lot of feedback on your microphone. So let's try again.
Yeah. So I was saying, how will you differentiate pharmacological adverse effects from the rest of the other adverse effects like biochemical, terrogenic, genotoxic?
Right.
Because in the end, everything will show up as a pharmacological outcome, right?
Right. Well, you're right. They're all adverse reactions. Okay. But with a pharmacological response, a good way of thinking of it, mostly it is related to, I would say, overactivation of a particular receptor, right? So if you overwhelm an opiate receptor, you're going to get hypoxia. If you give an overdose of epinephrine, you can achieve toxicological levels of blood pressure, high blood pressure. So I would link this pharmacologic response related to receptor interactions, where certainly teratogenic effects can have a biochemical basis, and teratogenic effects can also be from mutagenic, or just mutations, or just interference. I'm trying to think of another drug for teratogenic effects. In terms of embryonic development, different stages have to occur in a particular order of development. And if you disrupt a particular stage of development, that then can lead to a birth defect. Does that make sense?
Yeah.
Yes, Dr. Johnson.
But you're correct from saying that at some level, from a definitional standpoint, it's all biochemistry.
Right.
Another way of thinking of pharmacological is you could say, like physiology changes, just gross changes in physiological function. Any more questions? Well, another way drugs can cause toxicity is through activation of the immune system, where the immune system recognizes a drug or a molecule as being foreign, and then triggers an immunological response, and there are different types. Some of the most common are anaphylactic type reactions, which are mediated by IgE antibodies and typically involve GI tract, skin, respiratory tract, blood vessels, and one of the key players in these allergic reactions is histamine release. And histamine, what kind of cells is histamine typically stored in that gets triggered?
Mast cells?
Mast cells, that's right. And mast cells are concentrated on the skin, the GI tract, respiratory tract. So you can all sort of predict where the allergic response is going to be. And the release of histamine, what it does, histamine is a mediator of inflammation that dilates blood vessels, that then allows plasma to leak out of the blood vessel into the interstitial fluid, resulting in edema and then inflammation, because it also, other things that are released are chemotactic factors that then draw various kinds of white cells into the area, and you get a mess. Type 2 allergic reactions are mediated by different antibodies and typically involve the complement system, which is sort of involves a number of catalytic enzymes that get activated in a cascade. It's sort of similar to the coagulation system, but it's primarily targeting the blood system, circulatory system. And an example here is penicillin-induced hemolytic anemia. What is hemolytic anemia? Just definition.
Destruction of RBCs.
Right. And it can take a long time to recover from this type of cytolytic reaction. And then type 3 is an Arthus reaction that affects primarily bone, skin, and lymphatics. Commonly seen with certain antibiotics and other drugs. And the thing is that the antigen-antibody lodges in the vascular endothelium, resulting in what is called serum sickness. And it will resolve. And my least favorite, you could give me a quick show of hands. How many of you have ever had a reaction to poison ivy? Anybody? No? It is bad. It is bad. Just in terms of rash, itching, terrible. And this delayed hypersensitivity reaction, it doesn't occur right away. It could be the next day or 2 days later, and you start developing this horrible rash that doesn't go away. And it develops lymphokines that are chemotactic factors that attract neutrophils and macrophages that then release mediators of inflammation in the tissue. Then there are idiosyncratic reactions. These are reactions that are unexpected or unusual, and it's an abnormal response to drug exposure. And this is related either to extreme sensitivity to low doses or extreme insensitivity to high doses. Yes. You had a question? No? No, okay. And so what this relates to most of the time are variations, genetic variations in isoforms that are responsible for metabolism. So if, let's say, a particular enzyme normally would break down a particular molecule, and that enzyme is dysfunctional, the molecule will build up into the blood where it reaches a toxic range. And so normally you wouldn't have any problem, but because of this dysfunctional enzyme, small doses will produce a lot of response. On the other end, you could have extreme insensitivity to high doses, which could be related either to disruption in enzymes for transport of the molecule, let's say from the GI tract into the blood. If that transport mechanism is dysfunctional, you're not going to get an effect, even to high doses. Or you could have an enzyme that is overproduced and just breaks down the substance so quickly. You could give high doses and the patient is insensitive to the high doses. Some of it can be acquired. Here, a good example is ethanol. So let's say you have someone who is naive to ethanol, and they have one drink. It's not unusual for them to have an exaggerated response, typically because the base levels of, what's the enzyme that breaks down ethanol?
Alcohol dehydrogenase.
Alcohol dehydrogenase, very good. The levels are low, and so ethanol levels are then high. What's the mechanism of action of ethanol in terms of sedation? Does anyone know? It has an allosteric binding site on the GABA A receptor. Okay. However, someone who drinks regularly and has a relatively high intake of alcohol, they are going to have a diminished or become relatively tolerant because of enzyme induction of alcohol dehydrogenase. So when the person takes in the alcohol, it's broken down more rapidly. By the way, what's the metabolite for ethanol? If methanol is formaldehyde,
aldehyde and
Acetaldehyde.
yeah, the second one is aldehyde, and then the last one will be
acetic
the
acid.
Acetic acid.
yes.
Right. Yeah. Very good. So, at the cellular level, there can be, with non-lethal toxicity, cells can adapt by increasing cell size, that's hypertrophy, increasing cell number, that's hyperplasia, or decrease in cell size, which is atrophy, or metaplasia, which is change in cell type. Here I gave as an example cuboidal epithelium to squamous epithelium. What is the reference there? What causes a change in tissue lining of cuboidal epithelium to squamous epithelium?
Smoking causes changes.
That's right. Cigarette smoke will trigger changing the epithelium of bronchial tissue from cuboidal, actually ciliated cuboidal, to squamous epithelium, which then hinders getting rid of junk that's lining the respiratory tract. So there, in terms of reversible injuries, some changes to a cell can cause swelling of the cell related to lack of ATP for the sodium potassium ATPase pump, right? So, what role does oxygen play in aerobic respiration? It's the final electron in aerobic oxidation. And so if you don't have enough oxygen, you're not generating enough ATP. If you're not generating enough ATP, the pump pumps out sodium in exchange for potassium. And if you disrupt that pump, you decrease the polarity of the cell membrane, which then can disrupt intracellular fluids. So, a good example here would be, suppose someone has a myocardial infarction, right? So they have a coronary artery that gets blocked, lack of circulation to the heart muscle, the sodium potassium ATPase pump doesn't have enough ATP to function well. What happens to the cell membrane? It depolarizes. The cell membrane depolarizes. What happens? What happens to the cardiac myocyte? Yeah, you could have contraction of the myocyte. You could have disruption of normal electrical activity in the heart, which then can lead to cardiac arrhythmias that can become fatal. Another thing that can happen with reversible injury is cells can lose the ability to metabolize fat cells, and then lipids will accumulate in the cell in vacuoles, which then may disrupt cellular function. You see this a lot in hepatocytes. Can anyone give me an example of how liver cells can become essentially fatty? What exposure tends to result? Chronic exposure tends to result in loss of liver function with an accumulation of fat in the cells.
So, Dr. Johnson, it can be both like non-alcoholic and alcoholic.
Yeah, chronic alcohol.
Like chronic alcohol intake.
Right, chronic alcohol intake is classic for disrupting liver function. And if you do a histological examination, the hepatocytes have these fat-filled vacuoles that are disrupting hepatocyte function. And if the liver isn't working properly, you get things such as jaundice. You could also get abnormal bleeding because the liver is responsible for synthesizing clotting factors. Liver synthesizes circulating plasma proteins like albumin, and so people who are chronic alcoholics don't have adequate plasma proteins, and the result then is a loss of osmotic pressure. Fluid in the blood vessels then leak out of the blood vessels and typically accumulate in the peritoneal cavity, which is why people that are chronic alcoholics tend to have pot bellies. It's not fat, it's just fluid buildup. Any questions?
Sir, like I might be wrong in this. Maybe like, is it like possible due to viruses such as hepatitis virus and diabetes as well, the liver basically have become fatty?
The liver becomes what?
Fatty, like
that can happen. The fatty change in the liver is a generalized response to toxicity. Rather, if it's viral hepatitis or any other thing that damages liver cells, fatty change is going to be a response.
So, Dr. Johnson, I was reading this article, like especially like in China, there is an increase in the trend, like there is an increasing trend of youngsters drinking fructose-based drinks, and because of that, like the liver, our liver is like it is capable of capable of assimilating glucose, but not fructose. So, in those kids, like they've seen an increase in fatty liver because fructose kind of is assimilated in a different way compared to glucose. So there, it becomes more liponeogenesis compared to glycogen synthesis. So yeah, even that was one reason they suggested like people of today they're suffering from fatty liver because they're ingesting more fructose and less of glucose.
That's entirely possible. I'm wondering, I'm just trying to think back decades ago when I took biochemistry. Is fructose metabolized to glucose or not?
I think they can convert in their water cycle. Like there is one enzyme it can convert a certain portion of the fructose to the glucose, something like that.
Because structurally, fructose, I believe, is a ketone,
Mm.
and glucose is an aldehyde.
Yeah. Yes.
That makes sense. I think fructose is commonly added to different products as a sweetener
Mm.
because maybe it's less expensive than glucose. I'm much more a Splenda kind of guy, so I avoid both glucose and fructose when I can. But sometimes, especially in Western diets, and you go to the grocery store, it's hard to avoid products that have fructose in them. But that sounds reasonable. I'm not aware of very many cases of hepatitis deriving from excessive fructose intake. I'd be interested if you could do a quick search and come up with a paper and then send it to me as a email attachment. I'd be very interested in reading it.
Sure.
Thank you. So, aside from reversible injury, if the damage is too extensive, there'll be cell death. And this is a situation in which the disruption is so extreme that you can't restore normal function. And you can see a listing of things here that can essentially destroy oxygen deprivation, which destroys cellular metabolism. Chemical agents, I mean, they can be caustic. They could be highly reactive, like the intermediate for acetaminophen. Metabolism, lead, arsenic, cyanide. Cyanide, of course, interferes with is oxygen deprivation. Infectious agents can destroy cells. Immunologic reactions where the host's immune system is so extreme it kills cells. Genetic defects where, let's say, a particular enzyme is not, an essential enzyme is not available. Nutritional imbalances. I knew a man many years ago, 40 years ago, who was addicted to Coke. And all day long, he'd be drinking Coca-Cola. You'd always find him with a bottle of Coke in his hand. And he died, I think, in his 30s from diabetes. Physical agents, so mechanical, crushing of cells, and then people just get old. Certain cells have a particular number of divisions they can go through, and then they stop dividing. Also, with aging, you have aging cells, and then you can have a particular insult that the cell can recover from, but then repeated insults time after time, the damage accumulates over a period of time, and then as the cell gets older, it can't maintain homeostasis and it will die. So these are cell injury. Depletion of ATP, as I've been talking about, is huge. With the loss of there are so many enzymes that are ATP dependent. Things such as the sodium potassium ATPase pump. If someone is hypoxic, anaerobic glycolysis is much less efficient than aerobic oxidation, and you get a buildup of lactic acid, which then alters the cellular pH, which then can disrupt enzyme function. If you lose the integrity of the cell membrane, you can typically have an influx of calcium. Calcium is one of the major intracellular second messengers. So if you disrupt calcium, you can trigger all kinds of cellular responses that are inappropriate. Give you a key example. Someone has a heart attack, right? The brain is the first organ that's affected with cardiac arrest. And it's not the heart, it's the brain. And what happens is with loss of oxygen, you can't maintain the sodium potassium ATPase pump. There is an uncontrolled release of calcium from synapses. The calcium then is taken up in the postsynaptic membrane, where it is then accumulates in mitochondria in the neuron, disrupting mitochondrial function, loss of ATP, and the neuron dies. What I did for my master's thesis way back in 1985 was I set up a superfusion system where I put brain slices inside a chamber and then perfuse the chamber with solutions with varying levels of oxygen. And I was able to measure the release of calcium. And sure enough, calcium went up as oxygen levels dropped. A lot of gene transcription is dependent on ATP. Loss of ATP disrupts protein synthesis, which then can disrupt cell function. Here, continuing story. Damage to mitochondria, depletion of ATP. Damage to mitochondria causes the release from the mitochondria of cytochrome C. Cytochrome C is a trigger for apoptosis, which is programmed cell death. Influx of calcium activates phospholipases, which breaks down phospholipids, breaks down proteins, breaks down our activation of endonucleases, so you chop up DNA, and all of this will produce apoptosis. Another type of cellular toxicity is oxidative stress from the production of free radicals, highly reactive metabolic intermediates, which can be from redox reactions such as the Fenton reaction. By the way, is Fe2 plus, is that ferrous or ferric?
Ferrous.
Ferrous.
Plus hydrogen
Ferrous.
peroxide. 2 plus is ferrous. And so if you react that with hydrogen peroxide, you get this hydroxyl free radical, which is highly reactive, which then will bind to all kinds of structures, making them dysfunctional, especially proteins, or these things can lesion DNA. Radiation does the same thing. Enzymatic metabolism of endogenous chemicals. We already spoke about endogenous chemicals. What could be happening there? Highly reactive. Can't think of any endogenous chemical. Oh, I got one. Um, the conversion of L-DOPA to dopamine generates a free radical, which then can damage dopamine neurons in the brain. And so one of the problems with treating patients with Parkinson's disease by administering L-DOPA is you can increase dopamine concentrations in the brain, which then will relieve the patient of the symptoms of Parkinson's. But with the generation of this highly reactive radical in the metabolism of L-DOPA to dopamine, you can actually kill the dopamine cell. So although the patient feels better in the short term with the use of L-DOPA, the Parkinson disease itself progresses more rapidly. So that's one of the difficulties in treating patients with Parkinson's disease with L-DOPA. Reactive oxygen species, again, lipid peroxidation damages cell membranes. You get cross-linking proteins, which disrupts especially functional proteins like enzymes, and it can also damage DNA. If you damage cell membranes, you can interfere with phospholipid synthesis. Phospholipids are a key component of cell membranes. Can anyone name for me a key phospholipid found in membranes? Phosphatidylcholine, phosphatidylethanolamine, right? They're important because they're involved in signal transduction, especially with G proteins, right? Like phospholipase C, right?
Yes.
Which then gets cleaved into diacylglycerol and inositol triphosphate.
Yes.
Phosphatidylcholine. Increased phospholipid breakdown, reactive oxygen species, bad. Mitochondrial membrane damage, we already spoke about that. Damage to DNA and proteins leads to apoptosis. Now, if a cell is damaged but can be repaired, there's a mechanism for that called autophagy, which involves the removal and degradation of damaged cellular components. And this is especially important for terminally differentiated cells such as neurons and cardiac and skeletal muscle cells. There's a membrane in autophagy that surrounds or engulfs the damaged cytoplasmic material, and there is that something called an autophagosome, which then fuses with a lysosome that has degradative enzymes in it that breaks up the damaged proteins into amino acids or lipids or nucleosides, and those basic components then can be further metabolized and maybe reincorporated into the cell. So that's a mechanism for cell repair. If the cell is too damaged and beyond cell repair, there are two pathways that can take place. One is programmed cell death, which is referred to as apoptosis, and then there's non-programmed cell death, which is referred to as necrosis. And with programmed cell death, you can see there's this process. Organelles can still be functional, but the cell is broken up into small bodies. With necrotic cell death, the cell membrane ruptures, releases the cell components, the organelles are non-functional. You get, with necrosis, there's shrinkage of the nucleus, fragmentation and dissolution of the nucleus, breakdown of plasma and organelle membranes, and then enzymatic digestion of cellular contents. With apoptosis, there's condensation of the nucleus. You get these blebs in the cell membrane, these little bumps. The cell itself tends to shrink. The nucleus fragments, and then you get these apoptotic bodies, which are then phagocytized, and where they can then be disrupted. Programmed cell death, apoptosis, can be a normal process. And so in an embryo, there are a lot of cells that are there initially, but they need to be essentially wiped away. I think in the brain, there are a lot of cells. There are more cells in a newborn than there is, or an embryo, than there is in an adult. And so a lot of these non-functional neurons need to be paired away. And, or you can have hormone-dependent tissues which undergo apoptosis with the loss of hormones. And here, thinking about the estrous cycle, right? Where during what do they call post-estrus? Post-estrus, right? Where estrogen falls, and then uterine tissue essentially undergoes apoptosis and is sloughed away. Cell loss and proliferating cell populations. You can have triggered cytotoxic T cell reactions with cells that trigger apoptosis. This is mediated by receptor binding to a cell membrane. Then there can be apoptosis as a result of a pathological situation such as damage to the DNA, overwhelming misfolding proteins, certain viral infections, or atrophy of parenchymal ornaments after duct obstruction. This can be like a mechanical disruption. There are two major pathways for apoptosis. There's the intrinsic pathway, which involves increased permeability of the mitochondrial membrane, which then activates a mitochondrial sensor due to damaged DNA or proteins, which then releases cytochrome C, which triggers a cascade of events resulting in apoptotic nuclear fragmentation. The key here is the caspase cascade, which is triggered by cytochrome C. Then there's the extrinsic factor, where you have a receptor on the cell surface that binds a molecule, a tissue necrosis factor, that then binds activated T lymphs, which then once again activates this caspase cascade. So the common pathway is this caspase activation. Well, I think my voice is just about gone. So hopefully when we meet again on Tuesday, I'll be in better shape. Does anyone have any questions? Okay, well, hope you all have a good weekend.
Hello, sir.
All right, take
Sorry.
care.
Recording stopped.
All right, take care.
Thank you.